Tonight we have a special show lined up for you. We are going to spend the hour talking about Black maternal death rates and the health disparities that Black women face. In the United States, on average, Black women are 4 times more likely to die from pregnancy-related complications than white women. This number is even higher for Black women who live in rural areas. A number of factors contribute to this disparity. They include systemic racism, lack of access to quality health care, poverty. Even the strong Black woman schema weighs into things. This notion that Black women are superhumans, people who don't feel pain, maybe not even people, it dates back to the 1840s. This man, James Marion Sims, the father of modern gynecology, perfected the techniques used today in the OBGYN field by performing surgeries on Black enslaved women without anesthesia. Black women endured countless surgeries, their pain ignored, their concerns dismissed, their cries reduced down to a, quote, overreaction. Black women from all walks of life have dealt with these health disparities in the past, and they continue to deal with them today.
Who expects to walk in with this vibrant, healthy, brilliant, beautiful woman, and that we all leave later without her?
If these numbers were flipped around and white women were dying at the rate that Black women are dying, it would be a national crisis.
We were there for what seemed like an eternity, and finally some more doctors came back out and they told me that she was gone.
The Black maternal health disparities are not only a complex issue, they're also a public health crisis, a crisis that needs to be addressed. And that's what we're going to begin to do tonight. So joining me now to discuss is master birth doula and founder of Mama Glow, Latham Thomas. I'm also joined by Omari Maynard. He is someone who tragically lost his partner 2 weeks after she gave birth to their son. I'm also joined by Dr. Deidre Cooper Owens. She is the director of the Humanities in Medicine program at the University of Nebraska-Lincoln. I'd like to thank all three of you for joining me here. I'm going to start with you, Dr. Cooper Owens. When I hear in the United States that Black women are 4 times as likely to experience any kind of health disparity, but particularly this one, than their white counterparts, my first question is why?
That's a great question. As a historian, I try to put the puzzle pieces together where there are gaps in people's knowledge. And it really does date back to the 19th century, as you mentioned before, with men like James Marion Sims, but also others who did experimental work on enslaved women even before him. One of the easiest examples to use is C-sections. And there's a guy who's known as the father of the C-section, a French-born surgeon who first experimented on Haitian enslaved women and then moved to Louisiana in the early 19th century. And in the 1830s became the second man credited with a successful cesarean section. His name was Francois-Marie Prévost. And this is the interesting thing. From the 1830s until the 21st century, that means 2022, Louisiana disproportionately uses the bodies of Black women and birthing people for C-sections, which creates all kinds of complications. It literally has become a business on Black women's bodies. And so for me, it is about not necessarily having these historical boogeymen like a James Marion Sims or even a Dr. Prévost, but really talking about the racist building blocks of obstetrics and gynecology that were developed on Black women's bodies ever since the 1800s in this country.
Let me just follow up on something, because this idea that Black women were the right people to test stuff out on historically plays in again to this idea that they're either people who are superhuman and can't feel no pain, right, or maybe that they're not human beings at all, and therefore we can do whatever we want to them.
Exactly. I always call it a racial cognitive dissonance. So when I wrote about this in my book, there was a term I created called the medical superbody. And so that's the thing. The medical superbody can serve lots of purposes, right? It can be that human body that can withstand pain more than anybody else, because of course, the Negro is closer to a primate than any other human being. But then at the same time, there can also be these messages that the body is somehow a normal human one that you can experiment to cure the disorders and diseases of other people, i.e. white women. And so, there's a kind of double meaning that's attached to Black women's bodies. And unfortunately, we see that that hasn't changed. Just as you said, in the United States, it's the most harmful place for a Black woman or birthing person to become pregnant because of the racist building blocks of these particular medical branches, obstetrics and gynecology.
Latham, there will be people who will watch this and say, well, of course, we had an ugly legacy of racism and anti-Blackness, and Black women may have been treated like this or that. But this is the 21st century, for God's sake. This is a different world. Black women don't struggle with this stuff now. What do you say to them?
Well, we know that for a fact that they still struggle in this way because the perception hasn't changed. This is actually something that we see threaded through our medical system, but also in medical education, right? So medical students are learning that we're impervious to pain. They're also learning how to maltreat because, like Dr. Cooper Owens said, these forms of medicine were nascent at the time, but they are structural now. So these are institutions that we actually send women into and expect them to have different outcomes. But we can literally trace the disparities from hundreds of years, 200 years ago to now, and see that we are not doing right by Black women. And so it's critically important for us to learn how to navigate our current medical model, but also think about how to divest in the current medical system and further invest in things like midwifery, out of hospital birth, birth centers, empowering people to take this path, because we were also institutionally pushed out of this as a profession. And through credentialing came criminalization. And so many of us who could have studied under or become midwives or even descended from them, we don't have that in our lineages anymore, right? And so I think that part of it, part of like a shift to correct is really to invest in a future that we really want to design that really centers us as people, really centers our care as dignified, as safe, as affordable, as healthy, and ensuring that the people who care for us also look like us and come from our communities.
Later on in the show, we're going to talk specifically about what those alternatives look like so that, as you pointed out, we don't have to remain hostage to systems that don't serve us well. And this isn't just for Black women. I mean, there's a way that midwifery and other sort of methods would be healthy and helpful for everybody. But specifically, I think we see for Black women, one of the issues that comes up and we're starting to talk about is this issue of pain. It seems to be that the pain, the physical pain, we're going to talk about emotional, psychological trauma as well, but there's a way that the physical pain, Latham, of Black women and girls seems to be ignored by the establishment. Do you witness that? Do you experience that in the work that you do?
Yeah, absolutely. I mean, it was on the tip of my tongue, ignore, right? And so our experiences and our lived experiences are often ignored. And it's because we live in a society that is designed to comfort whiteness, right? And so at our expense. And so most of the time, as we're navigating spaces, people already think that we don't matter. And when we're thinking about healthcare specifically, where this shows up is, you said earlier, as we're opening the show, this idea of being powerful, being strong, right? We have to carry something that we've really inherited over many generations, this idea that we're strong and that we can carry carry a heavy load. And we take on so much that actually breaks us down, not only physically, mentally, and emotionally, but on a cellular level, right? We're impacting our DNA by carrying such a heavy load as well. And so, yeah, I see it in the work that we do. I see it also impacting care workers, right? When we look at doulas, when we look at people who work in our care system, look at the folks who are on the front lines disproportionately. Those are people of color, mostly Black women, and they are experiencing the most harm, the most the most indignities at the expense of the healthcare system, like by doctors or other people inside the healthcare system. They experience indignities from clients and patients inside of those healthcare systems. And because the system is structurally set up in a way that's almost like hazing sometimes, like they're at the bottom, right, inside of those spaces. So they're abused. And guess what happens when you come in and you're dealing with a nurse who's been abused? You're often abused as well. And so what's normalized inside of our medical model is a culture of disrespect and of violence. And so what Dr. Owens had said in the beginning, which is like, if you could take someone's body and if you could operate on them without consent and without anesthesia and do this, and it would be permissible, but not only permissible, it would be, you would also be rewarded and advanced in a field for doing so. This is at the crux of what our system is embedded in, right?
Welcome back to theGrio. We have been talking about Black maternal death rates and the health disparities faced by Black women. I want to bring my panel back in. We have Latham Thomas. She is a master birth doula and founder of Mama Glow. We have Omari Maynard, a dad who tragically lost his partner 2 weeks after she gave birth to their son. And we have Dr. Deidre Cooper Owens, the director of the Humanities in Medicine program at the University of Nebraska-Lincoln. Omari, I want to start with you. Again, there is a crisis happening here. And I think part of what is so bizarre to me is that so much of the world doesn't know that there is a crisis going on. They don't know that Black women and girls are dying more. They don't know that Black babies are dying more at birth. How do you think this happens?
I mean, there's a couple of reasons. I feel like, Latham and Dr. Owens, kind of really hit it on the head in terms of the history behind why we're at where we're at. And I think the underlining piece to this is the fact that when we're talking about birthing, because our generation is just so used to seeing C-sections that we just think that it's a normal thing. We think that this is exactly how it's supposed to happen. We feel like because our parents gave birth in the hospital, we have to give birth in the hospital. And then also just on the continuum, the timeline where when we're talking about women going into a delivery room, there's a lot of fear behind it. And there's a lot of fear mongering. So what ends up happening is that when you start feeling when our partners start feeling pain, the first thing is, because this is all we know, where's the epidural, right? As opposed to going through the whole process. And then once that happens, the next step is essentially, how can we do this as fast as possible? And this is what's been happening in our community. So for me specifically, when Shamani was giving birth to both of our children, it really came down to, they gave her maybe 30 minutes, maybe 45 minutes, the most I would say, to go through these labor pains. And once she wasn't dilating like the way that, they expected her to, or they wanted her to, it immediately turned into something else. And then once you get these epidurals, essentially what it ends up resulting in is the baby's heart rate going down. So then they have to now
this is an interesting
baby out. So once we're in this situation, we're really only stuck with, let's have this C-section. And unfortunately, like, Latham said, there are so many other better options that are out there, or alternative options that are out there that we just don't really discuss and talk about. And this is exactly why I'm just happy that we're having these type of conversations today, to let people know that, there are other things that you can do, and you can get support, and you can have professionals in the room that are catering to you as opposed to the hospital. Because when it comes down to it, it really is a system, and it really is about making as much money as possible.
Deidre, this is an interesting kind of historical shift, right? There's a moment where Black women can't get medicine, can't get drugs, can't get anesthesia, can't get anything. And now they're like forcing it down our throats almost systemically, and sometimes quite literally. How do you make sense of that shift?
Let me tell you the shift. And I often say this, and this is not me being hyperbolic, being dramatic. When you have a literal price tag on your head as someone who is enslaved and considered movable property, there is a concerted effort to make sure that you give birth in the healthiest way possible in that time frame, right? That doesn't mean that people aren't anti-Black and all of those other things, but they're much more invested in having an enslaved woman give birth to a child, and that child living and the mother living, because of the economic value attached to those bodies, those lives. After slavery, the narrative changes, right? In the way that you're talking about. So these bodies are no longer valuable. They're financial drains and burdens on society. And so all of a sudden you start hearing about the welfare queen, right? Always a Black woman, the irresponsible baby's mama. That's kind of the 21st century, version of the late 20th century's welfare queen. And so when those bodies and lives have no value for the nation, right? You can then test on them. You can give them dangerous drugs. You can continue to perform unneeded surgeries like those C-sections, in a way that creates money for the owners. And by owners, I mean the medical industrial complex, right? And so that's what has essentially happened. In freedom, the value of Black women's reproductive lives actually decrease in terms of the national project around Black birth and Black reproduction.
What I'm hearing, Latham, is that money's driving a lot of this, if not all of it.
Yeah, I mean, to add to what Dr. Cooper Owens was saying, I mean, this is how we get, compulsory sterilization, right? That takes place on our bodies. This is how we get campaigns around hormonal birth control that is not therapeutic necessarily, but that is experimental, and going into communities and pushing that. This is how we get to a place where now it's like we want to actually figure out how we can get you to have less babies, right? Becomes a different type of campaign, to her point. But I think the drivers around this, to add to what Omari was saying, this urgency is a big thing in hospitals, urgency and efficiency, right? And so how can we do this quickly, but also how can we do it without spending a lot of money sometimes? And also how can we make this, how can we create a setting whereby the people who are moving through this process are rushed, right? Because it's not about I know hospitality is inside of the name, but it's really not about hospitality when you go to a hospital, right? Mm-hmm. It should be, right? We should feel like that we come out of there and we feel well and we go home, but we're sending typically healthy people, right, into these settings, and people are not coming out alive. That is not a hospitable environment, right? That's a dangerous setting to be sending people into. And for us to knowingly be sending people into this situation, knowing that there are potential outcomes that are not only traumatic, but can be lethal. And so I think the urgency piece is critical, right? Because what do people talk about a lot? I didn't feel like I had time to make a decision. I didn't have enough information. I wasn't told. There isn't informed consent happening or models of consent happening in our current medical setting. And so a lot of people start to have things happening to them, except instead of being an active participant in their care and deciding whether or not to give or revoke consent for a procedure or treatment.
Welcome back to theGrio. Oftentimes, disparities in treatment for Black mothers can lead to death, despite complications actually being preventable. Sadly, that's exactly what happened to 30-year-old Shamani Gibson, who died 13 days after giving birth to her son.
After she gave birth, Shamani was complaining that she had really sharp chest pains.
The ambulance came. I'm telling them the symptoms.
Is she on drugs?
Next set of people come in. Is she on drugs?
They kept asking her mother, is she on any drugs?
Like, do y'all talk?
We waited a solid 12 hours.
She's gone.
Omari Maynard was Shamani Gibson's partner, who is now navigating life without the mother of his child. Omari, I want to spend some time and talk to you directly and separately about this issue. What happened?
To put it very simply, she wasn't listened to. It was medical negligence. After Shamani passed, well, first of all, she was 30 years old. She was healthy, didn't do any drugs, wasn't any complications. And she worked hard to keep herself up. And the pregnancy was absolutely fine. But they both came out the hospital healthy and fine.
So when you leave the hospital, there's no sense from the doctors that there's a problem. Everybody seems healthy. No red flags, no warnings from anybody on the medical team.
No red flags, no warnings, everything is fine. But the first couple of days, though, however, once she was in the house, she started complaining of having chest pains. She started complaining about having shortness of breath. It was hard for her to move the same way she did, to walk up and down the steps. And the thing is that because our family is already so deep-rooted into the community, specifically centered around maternal health, morbidity, and all the things that encompass that, we know people who were in the hospital that we were in. So we would call them specifically, telling them these exact symptoms that Shamani was having. And every time we spoke to them, what they said was that she's probably doing too much. Just relax, calm down. If anything gets worse, give us a call. But unfortunately, if you know anything about pulmonary embolisms, which is essentially what she passed away from, resting and sitting up is the last thing you need to do, because it allows a blood clot to move through the body. And that's essentially what came to her demise. When she passed, we knew that there was a problem, so we started calling the family in to come and help and support. And thankfully, we did that. So she did have time with family before she.
But that shouldn't have been. It was great that she was able to spend her last days surrounded by family and love, but these should not have been her last days. I want to take a break because I don't want to rush this story. I'm going to take a break. Everybody stay with us. We got much more on the other side. Welcome back to theGrio. We have been talking about Black maternal death rates and the health disparities that Black women face. I want to bring my panel back in. We have Latham Thomas, master birth doula and founder of Mama Glow. We have Omari Maynard, who is on the front lines combating healthcare inequities after losing his partner tragically. And Dr. Deidre Cooper Owens is the director of the Humanities and Medicine program at the University of Nebraska-Lincoln. So, Omari, before the break, you were talking about this idea that your partner had health concerns, had very clear problems. You said going up and down the steps, being out of breath, other challenges, and she's told to sit and rest when in fact the problems that she had were not going to be cured by that. In fact, they were worsened by that. When you look back at it now, should the doctors, in your estimation, have foreseen this? Was this something that could have been fixed if they'd listened to you differently or more or something?
Most definitely. When it's such a sad situation because of the fact that the 13 days after she gave birth, we went to the hospital 3 separate times. And each time was for something that was not necessarily her hospital visit for. So the first time we went, it was because they wanted to check Kari. The second time we went is because they needed to remove the staples from her C-section. And then the third time we went, they wanted to put us on some type of medical, some insurance plan that they wanted, or food plan that they wanted us to sign up for. Every time we went, though, we told them the exact same things that we told them when we were on the phone. But because of the fact that, again, hospitality is not a thing, right? It is essentially all about time. So because we didn't have the time for that, and her visit was, I want to say, after you have a C-section, it's about 3 weeks out, is where the follow-up visit is for Shamani or any birthing partner who has a C-section, because that time wasn't scheduled out for her, that we couldn't necessarily get those questions answered. So, yes.
So you have, just so I'm clear, so you have a health issue, you have a health concern, but even just from a structured, systemic, scheduling, bureaucratic perspective, they like, this isn't your day, this isn't your time, so this health issue you're raising can't be dealt with right now?
Essentially, that's what it was. At least that's what they told us. And like I said, we have people in the hospital who we know personally. The fact that she was Black and brown, the fact that she was on Medicaid, and the fact that we live in Bed-Stuy, Brooklyn, which is essentially one of the most expensive places to live in the world. But however, it's all divested from when it comes to our schools, to our hospitals, and all the other things in our area that we have to essentially live in. She wasn't taken seriously.
She wasn't taken seriously. Latham, when you hear a story like this as a birth worker, what do you think?
It's always heartbreaking, and also it's maddening because doesn't have to happen, right? And I think when we approach this as a community and think about what steps need to be in place for accountability, one thing I think is that already, we need to have better care, better aftercare when someone goes home, because most of the deaths that we see that happen on the maternal health continuum actually happen in the postpartum period. So it's not people who are dying in childbirth, it's people dying within the first few weeks of being home, like the first 6 weeks, but really the first year, right? And so we need to have after
TV, but TV doesn't tell us that, right? Because, you know, a lot of us get our understanding of health, you know, realities from representations in movies, films,
sure,
stuff like that, right? So what I'm used to hearing is, you know, if there's a tragedy at birth, that the mom doesn't make it through, that the baby made it, but the mom didn't. Something happens in surgery. Something happens before the baby is born. But the idea that everybody comes home and then somebody isn't okay, that's something we're not prepared for as a society, I don't think.
We're not prepared as a society, but also we don't have enough education so that we even know what to look out for when we're at home with family members, right? This is why it's so important to have people like doulas, to have care providers that you trust, that you can actually call. If they were able to get into these appointments and actually voice what was going on and someone was listening, they would have heard signs of things like, wait a minute, let us do a scan and see what's going on in her lungs, right? Same thing happens for people who have preeclampsia, right? They go home, they have headaches, they're having swelling, they don't know that they might have protein in their urine, and then things happen and advance in ways because, again, there's no screening. And so we need to do better with these postpartum bundles around screening for people. I think that everyone should have access to postpartum doula support. Birth doula support is important, but postpartum is critical because we're also able to see things and say, hey, this is something that we should bring to your provider, right? Let's get you into the hospital or to your care provider to get looked at. And I think that, you know, we have to continue to advocate. One of the problems with this is that we keep telling Black women, advocate for yourselves, speak up, but we are actually not supposed to have to speak up in a time like this. We're meant to actually just give birth and be vulnerable to be able to give birth. But instead, we're fighting for our lives. And so we need to shift the model completely, but really upend it, right? Because what we're talking about is really, at a structural level, everything needs to change.
At a structural level, everything needs to change. Dr. Cooper Owens, again, when you hear this kind of story, help me understand how Omari's story is in line with the history of Black folk, Black women in particular, in the medical establishment.
Yeah, when I hear his story, you know, it is unsurprising. It is heartbreaking, but unsurprising. I lived in Bed-Stuy when your partner died as well. And so what I do know about Bed-Stuy is it has maternal and infant mortality and morbidity rates that are even higher than the national average you provided for us, Mark. It's 8 times the number as opposed to 4 times. I actually had a sister-in-law and a brother who lived in the same neighborhood in Bed-Stuy and suffered the same kinds of complications. Thankfully, my sister-in-law is still with us, but it was a horrendous birthing experience for her because she wasn't listened to. And that is the thing that you see, right? From the colonial era through the 21st century, there are certain themes that remain the same. Victim blaming. Oh, Black women are too fat. They don't attend to medical appointments. If there's a negative medical outcome, it's the patient's fault, never the doctors or the institutions. And then this sense that Black women are being dramatic, that they are lying when they express that they have pain. There can be issues of criminalization. For instance, if the partner becomes upset because of the way that the birthing person is being treated, right? Where the partner might potentially get arrested. So all of these things sometimes are so saddening for me because I'm looking at records from the 18th and the 19th century, and yet the themes are very often the same in the 21st century around this birthing crisis. And so that is unsurprising for me because things have, some things have changed, others have remained the same, sadly.
Well, we're going to take a break, and when we come back, we're going to talk about how some of those things can change. We're going to think about some alternative birthing options that may be more responsive to our needs, our conditions, our culture, and our health realities. Everybody stay right here. Much more coming up after the break on theGrio. Welcome back to theGrio. Expectant mothers and fathers may be under the impression that there is only one way to deliver their newborn, in a hospital. But there are actually a number of alternative birth options for expectant parents to consider that fall outside the standard manner of delivery. And they might offer better and even healthier options for moms and babies. Joining me now to discuss this is Master Birth Doula and founder of Mama Glow, Latham Thomas. Latham, help me understand what these alternative options are. You don't go to the hospital. What do you do?
Well, I think it's important to really frame it more as ancestral options, right? Like these were our options that we had before we had our current medical model. And so midwifery is an incredible pathway for care for families. We have about 14,000 midwives in the U.S. right now. 6% identify as people of color, and then less than 2% are Black, as opposed to like 37,000 OBGYNs, right? And so we have a heavier obstetrician to midwifery ratio, whereas other developed nations have a higher midwifery to obstetrician ratio, and they have better birth outcomes. So really, if you can work with a midwife, right? If you're someone who is thinking about having autonomous birth, you want to feel like you have control, you want to feel safe, you want to feel like you're in a place where your needs are met, that you're heard, and that the care is centered around you, right? And if you have a healthy birth course already, this is a great option. Midwives work inside a hospital, so they're certified nurse midwives, so you can birth in a hospital with a midwife. You can birth outside of a hospital at home, if that is something that you desire, as well as in birth centers, which is kind of like a hybrid between having a home environment and a clinical setting. And so these are options that are available to us to invest in and also to fight for, because in some states, it's not even legal to practice midwifery, right? Midwifery has been divested in.
Still?
Yes, this is crazy, but yes, this is where we are in 2022, that we are still fighting to make sure that midwives can even practice, right? So it is on the legislative agenda, right? It is on the federal agenda. Doulas and midwives together are on the agenda. And so those of us who are interested in a different type of model, this is a good model for you to explore. Find out what midwives are in your community, what birth centers are near you. As you're exploring birthing options, this can be a great way for you to decide what feels right. And you still might ultimately choose a hospital, and that might be the right setting for you, right? But it's really important to just understand what the options are.
Thank you for that. Everybody stay right here. We're going to come back after the break and talk about other next steps we can do to help stem the tide of Black maternal death rates and Black health disparities. Stay right here. Welcome back to theGrio. We have been talking about Black maternal death rates and the health disparities faced by Black women. Let's welcome the panel back. Again, we're joined by Latham Thomas, Omari Maynard, and Dr. Deidre Cooper Owens. Thank you all for being with me today. I want to continue to, as we sort of wind down, think about what we can do to move this thing forward. Omari, one of the things you've been doing since your tragic loss has been to raise awareness. What's that been like?
It's been a roller coaster ride. One, because, you know, sharing Shamani's story, obviously, it just brings up emotional traumas that I have to personally deal with on a day-to-day basis. But one thing that it also does is it allows other people to share their stories, you know, and that's where we're at this point. So we created a foundation, myself and Shamani's mother, Shawnee Gibson. And the foundation is called the ARIA Foundation, and it stands for the Advancement of Reproductive Innovation through Artistry and Healing. So we use art, we use conversation, we use movement, and then we're also encompassing so many other things over these last 3 years. We're creating a postpartum awareness week. We're creating a children's book. We're creating a paternal app for fathers and birthing partners to help their partner through the gestation process and postpartum, and continue a holistic wellness atmosphere. And it is that thing where it is essentially, how do we create a model in which we just don't see and don't have? So we're really looking at it from birth to, you know, to adolescence to adulthood, in which we can create an atmosphere of community to help save lives.
And how are you coping sort of personally as a single parent?
Personally, for me, and I say this all the time, like I've been dealt for the worst possible situation that's ever happened in my life, I've been dealt the best hand. I've got an amazing community. Shamani's mother, Shawnee Gibson, again, has built a community around maternal health and community in general, just in a way in which I've just been encompassed, and I'm surrounded by people who love me and support the things that I'm doing. With that said, I know so many other fathers, and I speak to so many other fathers who, once their partner passes, people have said their condolences, and then a week later, they're out there to fend for themselves, trying to raise a child, trying to raise 3, 4, 5, 6 children by themselves, and just don't have that support. So for me, it's very important that, I pay it forward and really, like I said, try to create a community for everybody, because it is a road that is so tough to deal with, because when you are expecting life, you're never expecting to lose your partner in that process either, so the fact that you're holding this brand new baby and, and you've created life with somebody, in the understanding that we're going to take this child, and mold them into whatever we want them to be in the near future, and then all of a sudden lose that and try to figure it out yourself it's unfathomable. But
I can't imagine. Well, you have our love and condolences and support. And please consider your community to be that much bigger after today. Dr. Deidre Cooper Owens, you're an expert on the history of this. As we think moving forward, is there a lesson that history teaches us about what we should be doing?
Yes, I think that academics in particular can not just create knowledge for knowledge's sake, but you create knowledge to institution build, you create knowledge to support. And so in the ways that I do this work for a larger community of living people, right? Since I write about dead people. Tomorrow in Omaha, I am helping Black birth workers and reproductive justice activists with a community baby shower for Black mothers and birthing people. For medical colleges, organizations, institutions, I help to design curriculum that is more inclusive, that is, gets rid of some of those harmful stereotypes and misinformation. I have a project that is a grant-funded one in Lincoln, Nebraska. Has a very small Black population, but we're doing our best to try to track data around the birthing experiences of Black people. So there are all kinds of ways. And then the public speaking. I do everything from the big halls to the academic chitlin circuit, because I want to have people know the information going in so that they feel empowered.
Information is key. Empowerment is key, and information to get to empowerment is critical, and we're grateful for that. In the 2 minutes we have left, I want to turn to Latham for a moment, because I know you do amazing work, not just with Mama Glow, but more broadly in terms of supporting Black women and girls when it comes to birthing and other things.
Yeah, I mean, our focus now, particularly on the Mama Glow Foundation, is advancing birth workers. So through workforce development, creating other pathways for them to support community. So that's supporting midwives and doulas through scholarship support. And then also we have a college initiative. And so we have doula clubs on campuses. We're training people through our Mama Glow Doula homeschool program. And those are folks who are actually on path to go into medical school. So we're getting them in early. And these are mostly Black and brown folk who are coming through, who want to head into medicine and change the world. And so we're just, making sure that they get a different type of training before they head in, so that they can go and shake it up and do what needs to be done, so that we can create a new model that really serves our people in the future.
Latham, if you had a message to Black mothers right now, people who are expecting or people who are going through the journey right now, what would it be?
I would ask them to really lean into community, find folks who can support and anchor them in this process, and make sure that they have adequate education and feel the capacity to move through the process supported. And if something in you is telling you that something's not right, listen to that wisdom, that your intuition is wisdom and it will not do you wrong. That can guide you to better birth outcomes by listening to what's coming up for you inside. So we are always denied that. And it's really important for us to listen to that, because many of us would have different outcomes if we were trusting that wisdom to begin with.
I love that. Latham Thomas, Dr. Deidre Cooper Owens, Omari Maynard, thank you all so much for joining us. Everybody stay with us. We'll be back right after this. All right, family, we have reached the end of the show, but before I let y'all go, I wanted to throw a number at you. There's a study a few years ago that showed that Black people are 40% less likely to get pain medicine than their white counterparts, and 34% less likely to get opioids than their white counterparts. And when you break that number down for women, it's interesting as well. Black women are also considerably less likely to get pain medicine than their white female counterparts. And Black women have to have a pain score of a 10 at times to get the same medicine that white women can get at a 6 or a 7. What does this all mean? It means that the medical establishment is fundamentally racist and sexist. I know a lot of times when we hear words like racism and sexism, we think about just the person that calls you the N-word or the person that doesn't treat you right interpersonally. But when we talk about the systemic and the structural, we're talking about the way that being Black or being gendered woman forces you into a situation where you're going to get worse treatment. The stories we heard in today's episode are evidence of that. Black women and girls are treated differently in the hospital, even when the doctor doesn't identify as racist, even when the nurse thinks they're liberal, even when the healthcare worker voted for Obama or whatever they say to make them think that they're not racist. At the end of the day, the functional outcome of the system is that we get treated worse, that we die more often at birth, and that we don't live as long after giving birth. These are realities that Black women and girls face that are proof of a system that cannot save us. So we got two options. We can either repair the system so that we can get something out of it differently, or we abandon the system and produce a set of realities that work for us. Now, in this case, I'm saying we got to do both. We have to work and dismantle the way that the medical establishment works so that hospitals no longer treat us like runaway slaves. But at the same time, we can't be afraid to run away. At the same time, we have to go to doulas. At the same time, we have to go to midwives. At the same time, we have to locate all of the birth workers that can help give us the very thing that we had before this whole wicked system was built. And that is healthy options. I wish you all healthy options.